Hello and welcome to the Medicaid Insights Colloquium, also known as Mike. Thank you all so much for joining us today. I'm Will Shapiro. I'm an assistant professor in health policy and economics at Weill Cornell. And as usual, I'll get started by going over a few quick notes for our time together today. This session will run for about an hour, including 40 minutes of presentation, followed by about 20 minutes for Q&A. Because there are so many of you joining us today, we ask that you please refrain from using the raise hand function. And if you do have a question during the presentation, you can submit it at any time by clicking on the Q&A button at the bottom of your Zoom window. We'll get to as many as we can after the presentation. I also want to take a quick moment to recognize my fellow members of the Mike Planning Committee. That includes my colleague John McConnell at OHSU and Jamila Mishner, also here at Cornell. I should mention that Jamila will be cycling off her role with the committee this year after helping to found this series just about 3 years ago now. Her involvement has been invaluable in setting our course, and we want to thank her for her many contributions. All right. Now I have the pleasure of introducing our featured speaker today, Ann Dwyer. Ann is an associate research professor at Georgetown's McCourt School of Public Policy, and she sits within the Center for Children and Families. Her research and policy work focuses on Medicaid and CHIP, including behavioral health care. One of the reasons we're especially excited to hear from Ann today, however, is her history on Capitol Hill. Before joining Georgetown, Ann served as senior health counsel for the Senate Finance Committee and was in the thick of major healthcare legislation, including the reauthorization of CHIP and the American Rescue Plan. Ann is here today to lend us the benefit of her trained eyes and provide us with a very, very timely update from the Hill on Medicaid. As many of you know, the most recent CBO score on the reconciliation bill came out earlier this morning, just about 3 hours ago. The most recent estimates suggest we're going to see about 7.8 million additional uninsured from the Medicaid program. So, Ann, really thankful you're here with us today to give us a sense of where we are and where things might be going. So please join me in giving a warm welcome to Ann Dwyer.
Thanks so much, Will. It's great to be here today. There's a lot to cover today, so I'm going to go ahead and share my screen and just jump right in. So let me get that going. So a bit of an update on what's going on at the Hill. And Will, as you mentioned, it is, very timely to be having this conversation. So thank you to you all for the foresight to kind of schedule this at this point. So why don't we, again, just jump right in. So given that there is a fair amount to cover, I've broken today's presentation into kind of four main buckets. So I know there's probably a very good amount of Medicaid expertise and wonks on this call, but to give our conversation what I kind of feel is some important context, I wanted to set the stage a bit by providing a brief overview of Medicaid, including its role for children and families and its financing structure, and also mention some of CCF's latest work in this space. I will then move on to an overview of reconciliation, including current timing and process, or at least what we know of it right now. And finally, I will highlight some of the key Medicaid changes and cuts in the House reconciliation bill, including coverage impacts and other impacts. Then I'm happy to open it up to Q&A, and during that time would also welcome reflections from you all about how you're thinking about this and working on these issues. So first, I will start with an overview of some of Medicaid's key roles for different populations and communities. Again, relatively brief, and then move on to a few comments on Medicaid's financing structure. So overall, Medicaid, alongside its smaller but important sister program, the Children's Health Insurance Program, or CHIP, provides health coverage for about half of all children in the nation, including coverage for children in foster care, half of all children with special health care needs, including those children with special health care needs who may have private coverage but rely on Medicaid to help fill the gaps. Medicaid is also the primary payer of births in the United States and the largest funder of long-term care services, many of which are not covered by Medicare, like home and community-based services and nursing home care. And it's also the single largest payer of substance use disorder treatment and mental health services in the US. So again, I know a lot of you already know this, but just want to highlight the many roles that Medicaid plays in our country's healthcare system. And it's really an important role in the larger healthcare infrastructure of the United States. It's also important to note that when you look at Medicaid enrollment for spending by eligibility category, while the Medicaid expansion has received a lot of attention over recent years, the reality is that seniors and people with disabilities make up over half of federal spending, yet account for less than 20% of enrollment. So as we can see here on this slide, you can kind of see how different populations, we have enrollment on the left and spending on the right, how that's kind of associated with the different groups, and how the expansion group and adults group do make up a relatively smaller portion of spending in comparison. Median income also varies for different populations across the program. So notably, median income eligibility limits for adults in non-expansion states is only 34% of the federal poverty level. And as we can see in this slide, while some may talk about the expansion as covering just childless adults, the reality is that many low-income parents are covered through the Medicaid expansion in states that have expanded. So again, eligibility levels do kind of differ across populations, but just want to point out that there are a lot of low-income adults, low-income parents who also fall into that expansion group. It is not just childless adults, although childless adults also are covered by the Medicaid expansion in states that have picked it up. So Medicaid also plays a very important role in rural areas. CCF issued a report looking at Medicaid coverage in metro and small town and rural areas, finding that non-elderly adults and children in small towns and rural areas are more likely than those living in metro areas to rely on Medicaid and CHIP for their health coverage. I'll note we have some great state-by-state data and graphics on the CCF website if you're interested in learning more, or looking at, for those of you that will do state-based work, looking at your state, or just wanting to dig down a little bit more into different small town and rural areas. And of course, as mentioned, Medicaid is a key player when it comes to paying for births in the United States, with a number of states with more than half of births in the state financed by Medicaid. So again, as we can see here from this graphic, pulled from the Kaiser Family Foundation, there are a number of states, Louisiana, Mississippi, New Mexico, Oklahoma, to name a few, that have over half of births financed by Medicaid. And as a follow-up to CCF's report on the role Medicaid plays in rural areas and small towns, last month, we issued a report examining the role Medicaid plays for women of childbearing age. So according to this report, in 2023, nationally, 23.3% of women of childbearing age in rural areas were covered by Medicaid, as compared to 20.5% of women in metro areas, with 20 counties nationwide having approximately half of women of childbearing age covered by Medicaid. So again, this report, along with additional county data, can be found on the CCF website, including a listing of kind of those top 20 counties. So if you're interested in learning more, I would definitely encourage you to take a look on our website at that report. Okay, so a bit of stage setting on Medicaid, its many roles, how it's so important to our healthcare system and healthcare coverage for 70 plus million Americans who receive their healthcare and coverage through Medicaid. But now I just want to move on to a little bit more on financing, in particular federal financing of Medicaid. So this is not going to be a full Medicaid financing presentation, but I did want to highlight a few key things. So just as a reminder, when it comes to federal funding for Medicaid, Medicaid is a mandatory program. So this means it's not subject to annual congressional discretionary appropriations in the same way other programs may be. Medicaid also has an open-ended financing structure, so where the federal government picks up a fixed percentage of state Medicaid costs based on a matching rate formula, where the state puts up some of the money and then the federal government matches it. As a federal-state partnership, states generally administer the program, and they do this within broad federal rules, including around coverage of mandatory populations, mandatory services, as well as optional populations and optional services. And while the federal matching rate can vary for different groups, including and certain administrative costs, generally speaking, a state receives a standard federal matching rate or FMAP for the majority of their medical expenditures. So as we can see on this graphic, on this slide, that ranges anywhere from 50% to 77%, depending on the state, and is generally based on the state's per capita income, and again, is updated annually. But for the expansion population, just noting that this is a standard 90% matching rate for medical expenditures across all states for that population. So this is an example of the expansion population where you do have that higher matching rate. And as we can see here from CCF analysis, we did a National Association of State Budget Officers data for fiscal year 2024. Medicaid is the largest source of federal funding for states by far. So again, just looking at this, looking at federal funding to states, on average, 56.1% of that is coming from Medicaid. So over half of federal spending going into states, and again, much more in some states, is coming from federal Medicaid support and funding. However, Medicaid is a much smaller portion of state-based general funds, and much smaller than other items like K through 12 education. So often you'll see these two graphs kind of smushed together when it's just looking at overall spending. So it'll say, oh, states' Medicaid budgets are this much, and Medicaid's taking over this much of a state budget. Not that that's not important or relevant, but it's important, I think, to note, if you break these two out, that a lot of that money is coming from federal support. And some of it, of course, because of state matching, is coming from state support. But I think these two graphics really kind of highlight the federal support and then the portion of state-based general revenue funds that usually or typically go to support Medicaid. As a result, reductions to federal Medicaid funding can have huge consequences for states' budgets. And I'll talk about in a bit more detail, but there are kind of three buckets of cuts that we're seeing in the current reconciliation bill. So one, cutting federal matching funds directly. Two, adding red tape, causing eligible people to lose Medicaid coverage. And three, restricting states' ability to raise the state share needed to pull down federal funding. And again, I'll talk about this in more detail, but just kind of wanted to highlight those up front. And because of Medicaid's matching structure that I spoke about a few slides ago, under which the federal government matches at least 50% of costs, although again, much more in many states or for different populations like the expansion population, funding cuts, federal funding cuts or state funding cuts can result in a multiplier effect. So as a result, for let's say every $1 that is cut in state general funds or that a state can no longer raise to pull down federal matching funds, you see a corresponding and often much larger cut in federal funding, resulting in even a bigger total cut to the state's Medicaid budget overall. So we've talked a bit about the important roles Medicaid plays and its financing structure. Now we get to move on to some of the fun stuff. And I suppose that really depends on what your definition of fun is. So maybe I'll just say interesting stuff. But as a former Senate staffer and a self-described procedure nerd, budget reconciliation is quite an interesting process. It has a lot of unique rules around it, particularly in the Senate. And all of these can really shape a bill, its timing, and its process moving forward. So after touching on process and timing, I'll just get into the meat of the Medicaid, what we're seeing in this Medicaid reconciliation bill. But I did want to talk a little bit about reconciliation generally and how that could play into next steps, particularly in the Senate. So again, I'm going to just take a few moments to go deep down into the wonkdom of congressional reconciliation process to help provide some context to what Congress is kind of considering right now. I'll say we have a great an explainer on our CCF website kind of talking about some of this in a bit more detail. So we have a link at the bottom of the slide. Feel free to take a look at that as well if you'd like to learn more. But in short, budget reconciliation is an expedited legislative process related to revenues, so think taxes, and mandatory spending. So think Medicare, Medicaid, CHIP, ACA market subsidies, SNAP. Again, Medicaid is not a discretionary program, it's a mandatory program. So it falls into that mandatory spending bucket. And congressional budget reconciliation in the process is unique in that it allows certain legislation to move forward with approval from a simple majority rather than be subject to the filibuster and the usual 60 vote threshold in the Senate. So often you need, the supermajority in the Senate to get things done. That's not the case always when it comes to budget reconciliation. This is a privilege bill. Simple majority will suffice. And that's often why this process is pursued, because the majority may not have the votes to get to a supermajority on a bill, but they may have enough votes to get to a simple majority. However, there are constraints about what you can do through this budget reconciliation process. So as a first step, Congress must pass a concurrent budget resolution, which doesn't typically include policy specifics, but rather establishes some general budget targets and usually includes instructions to various authorizing committees to make reconciliation bill kind of generally deemed recommendations in order to meet those targets included in the instructions. So again, you have this resolution that is just, here's our budget targets, here's kind of our general instructions. It doesn't say how to get there. It's not the policy specifics, but it's kind of the intent. And you have to pass an identical budget resolution in the House and the Senate. The president does not have to sign the resolution, but you do need that concurrent resolution to kind of set up the process for budget reconciliation. After the budget resolution is passed, Congress can then move on to the reconciliation bill. However, in order for the bill or the provisions in the reconciliation bill to keep their privilege status and thus that simple majority threshold vote in the Senate, which again is typically the whole point of this process, the bill must meet certain budget rules, including what is known as the Byrd Rule. So again, we talk more about the Byrd Rule in the explainer on our website, and again, goes into much more detail on this and a few other items. But at a high level, in order to be considered under these expedited procedures in the Senate, in particular, where this Byrd Rule applies, the reconciliation bill and the provisions in it are supposed to be limited in scope and not include extraneous measures. So this includes things like measures that have no budgetary impact, because if you have no budgetary impact, how is that part of a budget process? Or measures that are outside the jurisdiction of the instructed committees. So again, you have this budget resolution. The resolution is the one that's telling which committees get to make changes, and they have to be, those changes have to stay within those committees. So if you make a change to a provision and that provision's outside of the jurisdiction of one of those instructed committees, you could run up, that provision could run up against Byrd challenges. The provisions must also produce a budgetary effect that is can't produce a budgetary effect that is merely incidental to the non-budgetary policy changes. So there's, again, a bunch of kind of technical rules in the Senate around this bill, around a budget reconciliation bill under the Byrd Rule that have to be in place in order for the bill or the provision within the bill to kind of keep that privilege status and keep that 50 vote or simple majority threshold. So I'll note that what is kind of called a Byrd violation, or a measure or provision that violates the Byrd Rule, doesn't automatically mean a provision must come out. Many times the provision will be taken out proactively, but if not, and it's included in whatever language comes to the Senate floor, then what it allows then is for a member to raise a point of order against the provision as extraneous. Hey, this provision is extraneous, and then typically that's sustained by the chair or the parliamentarian, and then they have to do essentially a vote, 2/3 vote to overcome that. So that extraneous non-budgetary provision to stay in the bill has to kind of meet that supermajority. So just long story short, something that runs into a Byrd Rule doesn't automatically always get kicked out. It could stay in, it could potentially even be in a final bill, but would have to come over a very, very high threshold, which is often why you see those provisions proactively taken out of the language. I will note that notably, Congress has used reconciliation multiple times over the past many decades, both successfully, and both on a partisan and nonpartisan basis. So a few examples. In 2022, reconciliation was used to pass the Inflation Reduction Act. It was used to pass the American Rescue Plan Act in 2021. the 2017 Tax Cuts and Jobs Act, and reconciliation was also the vehicle used for the failed 2017 ACA repeal and replace efforts that you may remember. And finally, I know, again, this is the last thing, really getting into the weeds here, but I did want to note that this Congress can consider or could consider another reconciliation bill for this next fiscal year. So essentially, they could do another reconciliation bill after this one, because this one is for this fiscal year, and they can do a reconciliation bill for next fiscal year. However, if they were to do that, the whole process starts over again. So they'd have to have a new budget resolution that would go through the House and the Senate, and then a new budget reconciliation bill with new recommendations from the committees. So there is an opportunity here potentially for another budget reconciliation process, but it would have to go through multiple steps again. So for current timing and process, the House and the Senate passed their concurrent budget resolutions, as I mentioned, in April, and this included instructions to the House Energy and Commerce Committee. This is the House committee with jurisdiction over Medicaid, to reduce federal spending by at least $880 billion over the 10-year budget window. Passage of the budget resolution in the House and the Senate was followed by committee markups in the House of their recommendation language and recommendations. So this included a 27-hour or nearly 27-hour committee markup in the Energy and Commerce Committee. However, the language did pass out of committee on May 14th, and then it was combined with the language from the other committees of jurisdiction in the House, including provisions focused on taxes and SNAP, as well as many others. And this was combined into a singular reconciliation bill that was brought to the House floor and considered and voted on in the early morning of May 22nd, right before the week-long Memorial Day congressional recess. So again, about, what is this now? What is time these days? About a week or two ago. So what's next? So here we are now. We are back from the Memorial Day recess. And by we, I mean the House and the Senate are back in session for the Memorial Day recess. So the bill is now being considered in the Senate. We are starting to see Senate committees release their recommendations, their version of the text. The Senate Armed Services Committee released their legislative text just yesterday. I believe that's the first committee that has released text in the Senate. We do expect more of the Senate instructed committees to follow suit over the next week or two. The Senate Finance Committee, which has jurisdiction over Medicaid, CHIP, the ACA tax credits, and taxes, the whole tax code, has yet to release their text. So we are kind of watching closely, and this will really, again, as these committees release their text, be an opportunity to see how similar or how different the Senate text is from the House passed version or language. In terms of timing for floor action or next steps on the bill, it's being reported publicly that the Senate majority would like to bring the full bill to the Senate floor this month. Again, that's just what's being reported by different news outlets. I will say, as a former Senate staffer who staffed multiple reconciliation bills on both sides, both were being in the majority where there was efforts to proactively move a bill, and then also in the minority responding to those efforts. I would say this is an ambitious timeline, but it may be possible as Senate rules are different than the House. So in the Senate, it's possible that the Senate could just skip any public hearings or markups, any public process whatsoever, and just have the committees release the recommendations. They put all the recommendations together into one bill, and instead just bring it straight to the Senate floor. And just, again, we don't see any 27-hour long markups in the Senate, but it is just packaged and goes to the floor. However, before this happens, the bill will have to go through the BIRD process I spoke about earlier. This is typically a closed door process with the Senate parliamentarian. So this is not like a public process. This is usually, individual meetings with the Senate parliamentarian, with the majority staff, minority staff. But it is an important part of the reconciliation process in the Senate, and it typically does take some time. However, it is likely that at least some of these conversations are already underway, especially as the Senate bill text continues to be released. So in addition, the Senate majority, in addition, kind of these procedural dynamics, they again may have substantive changes they may want to make to the House passed bill due to different member priorities. However, again, because we haven't seen the Senate Finance Committee text yet, we don't have a good understanding of how different or how similar it may be to the House passed bill. I will note if the Senate revises the bill, for example, they make changes to respond to BIRD or technical changes, and then they vote on passage of that modified bill, whether it be big modifications or little modifications, that bill would have to go back to the House to be voted on and then signed by the president because it does have to be the same language. So that is just another dynamic that comes into play with timing. We've talked a lot about process, a little bit about timing and just, some general stage setting. Now, I really wanted to get into the meat of what we are seeing in the House passed reconciliation bill, because that's the text we have right now. That's what folks are working off of. What is kind of out there? What has been passed by the House? What have we currently seen? So I'll note there are over 20 different Medicaid provisions in the House passed bill. This is not like one or two changes. There are, again, like 24 different provisions over many pages of legislative text in the House passed bill. So in the interest of time for today, I'm not going to speak to all of them. It would take this webinar and more, I think, to get through all of them and kind of detail that would be relevant and helpful. But I did want to call out some of the key themes and walk through a few of the different provisions and their impacts. So really kind of hone down into some of the what I'd argue some of the bigger provisions in the bill. But I will note we have a great explainer on our website. My colleague Edwin Park put out that walks through every single provision in the bill. I'll talk about this in more detail. We just got an updated CBO score today that this is being updated. So we'll have those updated numbers in there, but would really encourage you if you're interested in kind of digging down into each provision in more detail to take a look at that resource because it really is a great resource. Kaiser Family Foundation also has a really great summary that's just kind of a table, high level 1 to 2 sentences on each provision. So if you just want a higher level summary, that's a good resource too, but Edwin really does dig down into more detail, including CBO scores and things like that of the various provisions. So some of the key themes I'll be touching on today are Medicaid expansion related provisions and cuts, increased red tape and reduced enrollment, provisions prohibiting Medicaid coverage of specific benefits or providers, and provisions restricting the ability of states to raise their state share, including restrictions on provider taxes. So why don't we jump in? So when it comes to the Medicaid expansion, there are a number of provisions in the bill which target this population. This includes mandatory work requirements. So under this provision, starting no later than December 31st, 2026, the bill would require all states to implement mandatory Medicaid work reporting requirements for most expansion adults aged 19 through 64. We've seen some states or some past efforts where this has been cut off at, like, let's say 55, but just noting that this bill goes all the way through 64. These work reporting requirements would need to be satisfied for at least 1 month before application in order to enroll. So kind of like in order to even enroll, you have to satisfy the requirements. And then during enrollment for at least 1 month between eligibility redeterminations, which would be required every 6 months, which I'll talk about in a few moments because that's also a new change. So notably, while states would be required to automate the work reporting processes where possible, is the language, there is no requirement that states provide automatic exemptions for many individuals the bill states should be exempted. So this includes parents, guardians and caretaker relatives, dependent children and disabled family members, some people with disabilities, people with substance use disorders and serious and complex medical conditions, veterans with disabilities, and former foster youth. There's also flexibility in the bill language for the state to implement the work reporting requirements earlier than that 2026 date or make them even harsher. At the same time, states would not be able to waive any provisions of the work reporting requirements to provide additional exemptions or to broaden existing exemptions, nor would the US Secretary of Health and Human Services have the authority to allow for additional exemptions. So that's what's notable there is in the language that was included in the House Energy and Commerce Committee, there was language in there to allow the Secretary of HHS to essentially include additional exemptions. That language was taken out of the bill in the final passage as part of the Rules Committee on the House floor, along with a number of other changes, but that's one notable one. And I will say another notable change in this provision was they moved the implementation date up on this from 2029 to this 2026 date. So really expediting the implementation. Again, no later than 2026, but states could implement earlier. I think it's important to note here that most non-elderly adults in Medicaid already work, in particular in expansion, right? Nearly all others cannot work because they have disabilities or chronic conditions, are primary caregivers, or are in school. In addition, experience with Medicaid work requirements has shown that they have no effect on employment or hours worked, but that they do cut enrollment because people cannot navigate the work requirement system or successfully obtain exemptions for which they qualify. So these are just, I think, important dynamics to just be aware of in relation to this provision. So the Urban Institute examined the impact of a harsh, but I would say less restrictive 2023 work requirement proposal, which was modeled off of Arkansas's work reporting requirement waiver that they had a few years back and only would have applied to existing enrollees upon initial application. And it found that 5.5 million to 6.6 million expansion individuals ages 19 to 64 would be disenrolled from coverage because they could not successfully navigate burdensome processes and systems to report their work activities or obtain exemptions. And that, just for reference, constitutes about 36 to 42% of all expansion enrollees ages 19 to 64. Other Medicaid expansion related provisions in the House reconciliation bill include requiring states to conduct redeterminations for expansion individuals every 6 months. So I mentioned this earlier. So they would require states to do this every 6 months instead of 12 months, and requiring states to charge some cost sharing of up to $35 for every non-exempt service provided to any individuals enrolled through the Medicaid expansion who have incomes above the federal poverty level. In addition, providers would be newly prohibited or newly allowed, I should say, to deny services to any individual who cannot pay the required co-payment. So that is also a change relative to current law in the bill. The bill also eliminates the additional financial incentive that was included in the American Rescue Plan Act in 2021 for non-expansion states to take up the Medicaid expansion. Something that notably was a key factor in North Carolina's adoption of the Medicaid expansion in 2023. There are currently 10 states that have not expanded their Medicaid programs and who will no longer be eligible for this additional incentive to do so under this provision. So I won't go into too much detail on this slide, but I did want to note we have a helpful roundup of recent research on the CCF website on the benefits of Medicaid expansion on child health and family financial security. Not only does Medicaid expansion Medicaid coverage, I should say, benefit parents, but it can really benefit the entire family, including children. So if you're interested in that resource, again, definitely check it out on our CCF website. So in addition to Medicaid expansion related provisions, which was kind of that first bucket I talked about, there are also a number of provisions included in the House reconciliation bill that affect eligibility and enrollment for populations across the program, including children, seniors and people with disabilities. So this includes blocking implementation under a 10-year moratorium of a two-part 2024 rule to simplify eligibility and enrollment and increase participation in Medicaid and CHIP among children, seniors, and people with disabilities. There's a lot in this rule. And in fact, just again, we have a lot of great resources on the CCF website, but there's a lot in this rule. And if you would like to learn more about what is in the rule, we have a great explainer for my colleague, Trisha Brooks, on our website that talks through all the different provisions in the rule. Some highlights include eliminating CHIP waiting periods and lockouts. So children are not required to go through forced periods of uninsurance, which technically states can still do. So they can require children to be uninsured before they can access coverage. This rule would stop that or eliminate that. It also includes simplified enrollment processes for seniors and people with disabilities, for example, no longer requiring face-to-face interviews, but something that they could do online. So the interviews would still be there, but not requiring, for example, people with disabilities to have to come into the office to do an in-person interview. Without this rule, fewer children, seniors, and people with disabilities would be enrolled in Medicaid and CHIP. So the Independent Congressional Budget Office previously found that by itself, rescinding the eligibility enrollment rule would reduce Medicaid enrollment by 2.3 million people. So again, just rescinding this rule would have that 2.3 million person impact. Other changes in this bucket include limiting Medicaid coverage during reasonable opportunity periods for individuals waiting for their citizenship or immigration status to be verified, including due to Social Security Administration or Department of Homeland Security system delays, and also provision to limit retroactive eligibility. So just as a reminder, under current law, Medicaid coverage of medical and long-term care expenses is available for up to 3 months before application, assuming the individual would have been eligible at the time the services were received. So again, that's 3 months retroactive, but it assumes that you would have otherwise been eligible. This is something that can be particularly important for families facing a major medical event, or for an individual who suddenly sees a deterioration in health and requires long-term services and supports in a nursing home, where, for example, families may need time to gather asset information and documentation for the application while they're also managing this major life event for a loved one. And it may take them for example, up to 90 days to get this together in order to kind of finalize all of their application materials. However, the House Reconciliation Bill would limit retroactive eligibility in Medicaid for all populations across across the entire program, from the current 90 days to 30 days. So, again, a notable change. So in addition to provisions affecting eligibility and enrollment, in terms of this third bucket, there are provisions that target specific services, providers, or populations. So this includes prohibition on federal Medicaid and CHIP matching funds for gender-affirming care for all transgendered individuals covered by Medicaid. Includes prohibiting federal Medicaid funding for payments to providers such as Planned Parenthood, including federal Medicaid funding for preventive screenings, family planning, contraceptive services, and other primary care services provided by these providers. Just as a reminder, federal law already prohibits federal Medicaid dollars from covering abortion services outside the limited height exemption. So again, this is a defund or prohibition on federal Medicaid funding for all of the preventative and other services provided by providers such as Medicaid to individuals provided by providers such as Planned Parenthood for individuals covered by Medicaid. The bill also includes a provision cutting the Medicaid expansion matching rate from 90% to 80% for expansion states that provide coverage, including with state-only dollars, to undocumented as well as certain lawfully residing children and other immigrants, unless a state drops such coverage. So again, as a reminder here, current law already prohibits federal Medicaid funds from being used to provide coverage to individuals who are undocumented immigrants. So this would be a reduction for states that have expanded in their expansion matching rate from 90 to 80% if the state, for example, uses state-only dollars to provide coverage for these populations. Finally, as we're getting to the meat, and then we'd love to talk a bit about impacts. And sorry, I'm just checking the time. So in our last bucket of provisions, we have kind of what I would deem as restricting the ability restricting the ability of states to finance Medicaid. I do want to highlight in particular new limitations on provider taxes and state-directed payments. So I'm not going to go into too much detail here, as this topic could be an entire webinar in itself. And I'll note that we have an entire webinar on provider taxes on the CCF website. So if you are interested in learning more specifically about provider taxes and how they relate to state Medicaid financing, I would definitely encourage you to take a look at that webinar on our website. But just at a high level, for context, all states except Alaska have at least one provider tax, and many states have 3 or more provider taxes. So on the right here is a great graphic from Kaiser again that kind of highlights which states have provider taxes and how many. So under the provisions included in the House passed reconciliation bill, states would no longer be able to add new provider taxes, or increase current provider taxes to help close budget shortfalls, or to finance improvements to Medicaid programs like child eligibility expansions, or increased payments to hospitals and other providers. And again, this is not only freezing existing taxes. This is provision, again, would essentially freeze the existing taxes. They couldn't add new ones, but it also prohibits new taxes, including applying existing taxes to new types of providers. So it could be the case that a state has an existing provider tax that's on one provider group, and they may want to explore providing that same provider tax, just broadening it to additional providers to help finance parts of the program that under our read of the language would no longer be allowed. As a result, states would essentially be prohibited from raising any new additional revenue from provider taxes. And we know, for example, states have used provider taxes to close budget shortfalls during periods of recessions in the past. So it's typically been a pretty important tool for states in their Medicaid financing. So as we close out this section, kind of just again highlighting some of the provisions within the current House passed reconciliation text. I just again want to highlight this is just some of the provisions. These are not all of them. And if you're interested in learning more about some of the other provisions in the bill, I would encourage you to check out our explainer on our website. It's a great resource. We also have different blogs on the website breaking down some of these provisions. For example, which immigrant groups might be impacted by the immigrant language with the expansion penalty, kind of in more detail. So definitely take a look at that explainer, and then additional blogs on our website, really trying to get into the weeds of our understanding of some of these provisions a bit more. So finally, let's move on to impacts. So Will mentioned we got a new Congressional Budget Office score this morning. I was frantically updating this slide right before we hopped on. So as I mentioned earlier, the Congressional Budget Office is a nonpartisan federal office that provides budget and economic information and estimates to Congress. And I will note these numbers are typically provided over a 10-year budget window. That's typically how CBO operates. They look at the federal effect only over the 10-year budget window. So again, just this morning, CBO released an updated estimate of the budgetary impact of the reconciliation bill as passed by the House. Previous estimates were of language that was passed out of the various committees. But as I mentioned, like with the move of the date on work requirements from 2029 to 2026, there were changes that were made to the bill in the House Rules Committee right before it went to the floor. So this estimate incorporates all those changes. So according to CBO, the bill, according to my math this morning, includes over $860 billion in gross Medicaid cuts over the 10-year budget window. And again, it's important to note that the majority of these changes are permanent, so longer-term effects would be even greater. So this is just within the 10-year budget window. You look out the next 10-year budget window or after that, you will likely see these impacts increase even more. So overall, combined with the ACA changes included in the bill, according to CBO, net uninsurance would increase by 10.9 million, including 7.8 million individuals under Medicaid relative to current law. According to previous CBO estimates of the Energy and Commerce Pass language, this would include 1.3 million seniors and people with disabilities in Medicaid. The graphic on the right from Kaiser is based on slightly older language before additional changes were made at the House floor. So it's really, I think this graphic's based on the committee passed language, but it's similar and kind of just is here just to give you a sense where a lot of these cuts are coming from. And it's also important to note, lastly, that these numbers on coverage do not include the expiration of the enhanced marketplace premium tax credit. So for those of you who might be following some of the ACA dynamics, there were some enhanced premium tax credits. Those are set to expire. Extension of those is not currently included in this bill. And so the CBO estimate does not include those numbers, but if those tax credits were to expire, which right now they are set to expire, that would have further increases on the uninsurance rate, likely in the millions. So I'll note that, again, CBO typically only provides federal level impacts. However, the Kaiser Family Foundation and Manat Health, in partnership with State Health and Value Strategies, have put out some additional analyses of state level impacts of the House passed language. So according to Manat Health, for example, total cuts in Medicaid expenditures, taking into account federal and state funds, will reach 1.3 trillion. So again, if you combine not just the federal funds that CBO looks at, but also the state funds, their estimate is 1.3 trillion over that 10-year window. And again, this is expected to vary by states, with expansion states hit the hardest, but all states impacted. Similarly, they've also put out data on state level enrollment impacts. According to the Manat Health analysis, an estimated 1 in 10 Medicaid enrollees will lose coverage nationally, with some states seeing reductions over 15%. According to their estimates, the number of people losing Medicaid coverage could be as low as 6.8 million or as high as 10.7 million. Again, now we have this new number, 7.8 million increase to Medicaid uninsurance from Medicaid coverage losses from CBO. They also have some good data in there about breaking down population level impacts by pregnant people, seniors with disabilities, Medicare enrollees, children of the moratorium and effective repeal of the eligibility enrollment rule, and a lot of additional information that I think is really helpful. And again, it's state by step. They have some state by state level information. And then I'll just note the Manat estimates. They note that the penalties associated with the expansion FMAP reduction because of coverage for immigrant populations, which they expect would impact at least 19 states, would exceed nearly or more than 100 billion over 10 years. And as a result, it's likely that all or nearly all impacted states may have no choice but to drop coverage for immigrants, given the size of that penalty, included in the reconciliation bill. And as far as I know, a lot of these coverage impacts are not included in their estimate. So given these various dynamics, again, states would be left with very challenging choices. Ultimately, significant cuts to federal Medicaid funding result in large cost shift to states. States would have to dramatically raise taxes or severely cut other parts of their budget, especially K through 12 education and higher education, which constitute on average 43% of general fund budgets in states. The restriction on provider taxes at the same time would make it far harder for states to maintain current spending, let alone raise revenues to compensate for losses in federal funding. So what's, I think, more likely is states would have to make deep, damaging cuts throughout their Medicaid programs, affecting everyone, not just those in the expansion group, with Medicaid coverage, and all providers and plans that serve them. I'll also note that while I don't cover it here today, and I am admittedly not an expert on this topic, changes to SNAP, which are in the reconciliation bill, are also expected to put immense additional pressure on state budgets on top of the Medicaid reductions. Okay, so I know we've covered a lot today, and I'm going to wrap up so we have some time for Q&A and reflections. But I did want to try and end a little bit of a high note because I know this is a lot to take in and it is an evolving process. Kaiser did a really great survey of kind of views on Medicaid in the spring. And I just want to note overall, Medicaid is a highly popular program with the public. A majority of the public say that Medicaid is important to themselves and their family. Over 9 in 10 adults say Medicaid is important to their local communities. But there's also work that has to be done in terms of education. So most of the public is unaware that most working adults on Medicaid are employed, and over half of the public doesn't realize that Medicaid is the primary payer of nursing home and long-term care services. So there's often a misconception that Medicare is covering these services, but the reality is that Medicaid is the primary payer of long-term services and supports in the United States. And then I'll also note that while the bill did pass the House, and according to reports, the Senate is actively working on advancing their version with committees releasing text. There are still a number of steps the bill must go through, including being brought to the Senate floor and going through what is known as a Senate vote-a-rama process. Just as a reminder, during the 2017 ACA repeal and replace debate, which I will note, while it's called the ACA repeal and replace debate, and it also included that bill a number of large cuts to the Medicaid program in the hundreds of billions of dollars. That bill also passed the House, but it ultimately died in the Senate floor when Senator McCain and other senators voted no on that text. So with that, I've spoken a lot today. So I'll just note again, I've mentioned a lot. We have a lot of great resources on our CCF website. We got state fact sheets. We have different issue fact sheets. Some are longer, some are shorter, depending on what different needs are. And we have a lot of great state level data, including graphics, data on Medicaid and CHIP coverage by school district across the country, across school districts. And for more timely updates, again, we have a blog where, as things are happening relatively quickly, we update that. We have a weekly newsletter, if you're interested, that you can subscribe to on our website that kind of highlights different reports that we put out and new information put out on the blog. So with that, I'm going to stop sharing my screen and we'll turn it back to Will. And I'm happy to answer any questions, or again, I'd love to hear your reflections as well.
And well, thanks so much. That was a tour de force, and yeah, thanks for all the really timely work that you and your colleagues at CCF are doing. It's super helpful for those of us trying to follow along. So just a reminder for folks listening in, if you do have a question, please throw it in the Q&A box, and we'll try to get as many as we can in the next few minutes. Maybe we'll start with politics. It might be an unfair question, but can you read the tea leaves a bit? What do you think is going to happen in the Senate? Do you think that the bill that came out of the House is the bill that will become law? Do you think there are particular provisions that are at risk? What is your prognostication at this point?
Yeah, so I'll say this is just me speaking for me and all speculation at this point. I think it kind of depends in part on the timeline, right? I think if there is a real desire to move the bill, let's say in the next 2 or 3 weeks, it will be challenging to make huge substantive changes, go through the BIRD process, get all the members in line, bring that to the floor in 2 to 3 weeks. I think if the desire is to move very quickly, I think a bill that looks more akin to the House bill, I do anticipate there will be some changes. But a bill that looked more akin to the House bill just is one that is easier to move quicker through the process. So I do think that there is this dynamic of where are members and their priorities, where are things they're concerned about, or that that aren't in the House bill that they would like to see, versus this desire to move the bill quickly. And some are reporting that they want to get to the president's desk by July 4th. So that is a dynamic I'm sure that they are working through now. I will say there is also another dynamic, which I didn't mention in my presentation, but is important here, of the debt limit. So they're included, and this is outside of Medicaid. There is a provision in there to address the debt limit, which, according to the administration, may have kind of an August deadline. And so that is something that also has to be addressed. And right now, it seems like they're trying to address that through the reconciliation process. So that's another kind of, I guess, kind of deadline in place. And then the last dynamic here is that, as I understand it, this bill would have to be done by the end of this fiscal year, federal fiscal year, which is the end of September. So again, you have this desire to kind of move quickly, plus you have the debt limit in August, plus you have an expiration of like they had have to do a new reconciliation bill and start the process all over again, at least as far as I understand it, if this were to go past this current fiscal year. So there are some kind of, I guess, deadlines or some pressure points in there. But again, what's being reported in the news is that they'd like to move very quickly. So to me, that doesn't seem to jive with a lot of substantial changes. But again, we'll have to see. And then there's the bird process, which, I don't know. There's been a lot of Medicaid done and a lot of reconciliation bills, so I'm not sure we'll see huge changes there, but you just never know.
Got it. Thanks. Um, in terms of the substance of the bill in its current form, we have one question that touches on the work requirement exemptions or exclusions. Can you just maybe speak to that in a little more detail in terms of what the current language is and what flexibility states do or do not have?
Yeah, so I will note, as I noted in the presentation, and we have, again, I'll find it and put it in the chat. We have a great explainer on our website that walks through these in more detail. There are a few automatic exemptions and then a lot of where you can exemptions. So the idea is that these different populations would be exempted, but it's not clear that they would be automatic, and that would likely be up to the state. So I guess that's the big question of how much do you have? Yes, in theory, you're exempted, but like, do you need to go to get a doctor's note? If you don't have Medicaid now, how do you get that doctor's note? Um, there's like a retroactive ability for states to look back on your work period. So like, what if you work, but then you like lost your job for a month, but then you work again, but if they're requiring verification every month, then you didn't meet that month. So there's just a lot of questions in there about implementation of how all of this is going to work. They did include language in there that CMS has to issue guidance relatively quickly to states because again, a December 31st, 2026 timeline to implement this and to make these types of system changes, assuming this bill moves forward, is incredibly intense. As we saw with the unwinding of the Medicaid continuous coverage requirement, things can go wrong with when you're talking about kind of system changes, issues with red tape, mailing address changes, all of the like. We saw a lot of this happen in Arkansas. You have to go to a website to get a portal and you need a PIN and they mail you the PIN and you didn't get the mail and the PIN because you changed your address, things that have nothing to do with whether or not you're actually working, but that can potentially create barriers to people being able to demonstrate that they either are working or that they meet one of the exemptions. So again, a lot of open questions there.
I guess turning to impacts, we have one question about whether the cost impacts you cited from CBO and others also include any potential sort of broader economic downturns. And I know there's been some chatter about this online today. This is not yet a dynamic score from CBO. And so presumably if there are broader macroeconomic effects that, have implications for Medicaid enrollment, that's not reflected here, but could be reflected in future dynamic scoring from CBO. Is that right?
Yeah. So as far as I know, we haven't seen dynamic impacts. Okay, he'd always be like, go back to our website. We do have some blogs on our website about economic consequences. I'll note historically, I have a blog on this with my colleague, Kelly Whitener. Historically, when we see, who knows what's going to happen with the economy, but historically, when we see economic downturns during COVID-19, during the 2008-2009 recession, Congress has actually acted to increase federal support for Medicaid, right? So there is this dynamic of like what is to come from this. And then at the same time, federal support for Medicaid is actually decreasing, right? Like during COVID, we saw an FMAP bump for states. That this is kind of the opposite of this, right? That you're ratcheting back support while potentially there could be some other economic consequences. So yeah, as far as I know, I haven't seen those dynamic scores, but it's a good question and something I think that's worth exploring further.
Great. Well, thanks so much, Anne. We're unfortunately out of time. It'd be great to keep chatting for another hour or so. But we'll have to have you back once we know what's finally in the law.
And lastly, I'll just say, Will, I note that one of the questions was about timelines. I'll say in that, I see there's not a chat, so I can't throw it in, but maybe you all could send it around as a follow-up, or again, it's I think on the front page of the CCF website. In our explainer at the end, we have an entire chart of implementation effective dates. Some of the effective dates are, for example, as far as we can tell, no longer being able federal funding for care for gender affirming care would be effective upon enactment. Other ones are a few years out. Work requirements are 2026. So they're kind of all over the place, but we have a table at the end of that explainer with all the effective dates for all the provisions if you're interested.
Great. Thanks so much, Ann. Really appreciate it. And yeah, thanks so much for the wonderful presentation today.
It's great to be here. Thanks so much for having me.
Great. Well, thank you all for joining us. You'll be receiving a 2-question survey about this session to help us make the program better in the future. We'll see you again when we resume this fall. That's a Wednesday, September 17th session with Dr. Jane Zhu from OHSU. She's a clinician researcher who's digging deep into Medicaid managed care along with a host of other topics. So please don't miss that, and you can RCP for that session on our website, MedicaidInsightsColloquium.com. Thanks again, Ann Dwyer, so much for joining us, and all of you for joining us today. And see you again here in just a few months. Thanks so much.